Good morning. All protocols observed. Thank you for this opportunity to join you in the 4th National ECD Stakeholders Conference. So I head the Division of Neonatal and Child Health and was tasked to present on pediatric care amongst COVID-19 pandemic. So the outline of my presentation, I'll briefly take you through our mandate, our vision, our mission, our 4 indicators that we track. Then we'll discuss briefly about the COVID-19 pandemic and its effects on children, and look at performance trends of key tracked indicators during this period and lessons learned. So our vision at the Division of Neonatal and Child Health is a Kenya where all newborns and children survive, thrive, and live to achieve their full potential. We also have a vision that to ensure survival, the health, development, and well-being of all newborns and children in Kenya through promotion of evidence-based interventions, which are high impact. More often, they're also low cost. And also to create an enabling environment for effective delivery of quality health services at all levels of service delivery. Now, our core mandate: to reduce newborn and child mortality and morbidity due to preventable communicable diseases. Communicable are the infectious diseases, and our top killers in Kenya are diarrhea and pneumonia, the under 5, and also significant contribution by neonatal mortality in the first month of life. We also have a mandate to reduce this morbidity and mortality due to non-communicable diseases and conditions, which mostly affect children between the age of 5 to 10. And also to promote access to quality and comprehensive early childhood development interventions for all children, especially in the first 1,000 days of life. And this is where we implement the nurturing care framework. Also mandated to promote interventions to end all forms of malnutrition and address nutritional needs amongst newborns and children. And overall, to create an enabling environment for us to be able to deliver these quality newborn and child health services. So a brief look at the numbers where we were. This is from the Kenya Demographic and Health Survey of 2014. We plan to conduct one next year, so we'll see how we've performed. So we can see over time from when we've been tracking these indicators from 1978, 2014, we've seen a general improvement in the survival of our under 5s, our infants and our neonates. The neonatal, when I say a neonate, I'm referring to a baby who's less than 1 month old, an infant, the child less than 1 year, and then there's the under 5 child. So current estimates from this year have us at 21 deaths per 1,000 live births for the neonatal mortality. For the infant mortality at 32 deaths per 1,000 live births, and at 43 for the under 5. It's important that I note that majority of deaths in under 5 children, up to 46%, occur in the first month of life. That is where we focus our priorities and our interventions. So then came COVID, first case in March of 2020. So as with all other sectors, there was, and especially the Ministry of Health, there was a refocus of priorities of activities. We were all tasked, we were all task shifted to support the country's efforts towards fighting the COVID-19 pandemic. So at both ministry and at partner level, we had reprioritization of activities, which meant that resources were also reallocated, and also meant that the partner support that we were receiving for some of our interventions for neonatal and child health were directed towards fighting the pandemic. And indeed, this was the same across many sectors and for both state and non-state actors. So this had a ripple effect on our programming, and we caused the negative impact on child survival and development. So there's something called the hidden impact of COVID-19 on child well-being. We were following the numbers. We saw that the children who were infected or indeed succumbed because of COVID-19 were not as significant as adults. However, there is the hidden impact. And this came from an analysis by Save the Children in 2020, which says the impact that we are not able to see at face value. So what happened, the first thing was there was closure of non-essential health services and hesitancy to access healthcare. You remember, people were staying away from hospitals. Hospitals were also closing down the so-called outpatient clinics because they are non-essential, and they were only attending to emergencies. Hence, the ministry then came up with, immediately realized that there was going to be an adverse effect on our indicators. So there was a guideline that was released about continuity of essential and non-essential health services during COVID-19 with guidelines. We know there's also disruption in school attendance. For about 7 months, children were at home. They were not accessing education. We know for some counties, for some regions, these schools are the source of these child's, where they can play, where they can interact with other children, where they can even access a meal. So this disruption had an effect on the child. There was also limited access to the justice system before they reorganized because of closure of the courts, and hence delays in some of the judicial processes. And parents and caregivers were also affected economically. So this threatened food security, so people migrating. And we all know the important role of a caregiver. If a caregiver to a child is not emotionally, mentally, if they're not in the right space, this can affect the care that they give to their child. There's also some data that we're able to access from our health information system about the impact on violence against children. So I picked 3 years, same period in time, to compare the number of cases that were being, these are the total sexual gender-based violence cases presenting in health facilities. So if we look at the age group 0 to 9 years, there's a change. January to July 2018, there were 985 cases. Then January to July 2020, there were a slight increase of 1,071. But we see that majority of children between the age of 10 to 17 years, there was almost a doubling of cases from January to July 2018 to July, and comparison the same period in 2020. And these are cases that present to health facilities, and we do know a significant number of cases go unreported. So our response, we developed guidance on service delivery. Now innovations came up and we all went digital, virtual. We held trainings and and also sensitization meetings through the digital platforms. We did participate as a division in our national COVID-19 guidelines for children. We managed to conduct an assessment to monitor neonatal and child health service delivery, and also at the same time strengthen data reporting at both county and national level, and collaborated with other sectors to give the children a voice. So I'll quickly take you through our key tracked indicators. Like immediately we noticed a drop in outpatient attendance for under 5 years. This is the time when there was hesitancy to access health facilities because of the COVID pandemic. But also we remember in the last months of 2020, there was an industrial action that affected service delivery. Quickly looking at children presenting with symptoms of pneumonia. Next slide. Please move the slide. Next. Next. Yes, I've explained about the outpatient attendance. The next slide, please. Yes, so the red line that we can significantly see is the year 2020. We had a reduction in the number of children presenting with symptoms of pneumonia. Slide. Also, under 5 diarrhea trends, children who are pre-treated presenting with symptoms of diarrhea also significantly reduced. We could attribute this to improved eye infection prevention control measures such as hand washing and improved IC practices during COVID. Next slide, please. However, neonatal deaths have not changed. So we actually have to do we're doing a process of doing a deep dive because we are seeing our facility reported neonatal deaths were not affected. So what is it more that we can do maybe at community level to intervene? Next slide, please. So the next 2 slides are just a snapshot of our reported under 5 COVID-19 cases. So this may have changed. It's now about 2,000 cases. The mortality is still at less than 30 children. Next slide. So that's under 5. And then the next slide is under 10 years. So we did not have a large number of children being or suffering from COVID complications, as the adults have been affected, and most were traced due to household contacts. Next slide. So I'll wind up in the next 1 minute about the lessons learned. So we have learned that we have to be intentional in our programming for children in emergency settings, especially as the Ministry of Health, because these children are unique and their needs are unique. We also learned the importance of data to use in decision making and to strengthen this data collection at both facility and county level, and interrogation of this data and using it for multi-sectoral collaboration. Then the importance of flexible systems and structures to respond to emerging health issues, such as this pandemic with innovation. Teamwork cannot be emphasized. We all need to come together for ensuring our neonates and children survive. And the fact that a strike happened within a pandemic, needs to be prepared for this eventuality. It shows that anything can happen. And also the importance of policy and guidelines as a division. And this needs to take into account the environment at which we are in operation. And community health is a game changer. We are delivering services even for our newborns and children through the community health volunteers. So we need to strengthen our community health strategy programs.